Hello everyone, so we are doing derma today. Features of dermatological disorders in children and newborn dries and skin disorders are common but need to be distinguished from serious permanent conditions. A topic eczema affects up to 20% of children. Skin infections and infestations, especially viral warts and head lice, are common in school-age children. Acne is troublesome for many during adolescence. Skin complaints are common in children of all ages. The history gives important clues about the possible origin of any lesion. The child's age will often determine the most likely causes. Acute or chronic, recent or ongoing febrile illness suggests that rash may be one of the exanthema of childhood. The rash is shared by family members or contacts are frequently infectious or present infestations. Scabies, is the child otherwise well, or is this part of a systemic illness? Is it itchy or otherwise causing upset? Examination will reveal distribution and nature of the lesion. The newborn, the skin at birth is covered with a chalky white greasy coat. The bone is caseosa. In the preterm infant, the skin is thin, poorly keratinized, and transepidermal water loss is markedly increased when compared with the term infant. Thermoregulation is also impaired as the preterm infant lacks subcutaneous fat and is unable to sweat until a few weeks old, whereas the term infant can sweat from birth. Common nevi and rashes in the immediate newborn period are described in the examination of the newborn infant. Two common skin lesions appear in the first few weeks of life: sebaceous gland hyperplasia and miliaria are described. Other newborn conditions like just this chapter are uncommon. Sebaceous gland hyperplasia presents as multiple tiny yellow papules on the nose, cheeks, and upper lip. They are a manifestation of maternal androgen stimulation resolves by a few weeks of age. Miliaria characterized by erythematous papulovesicular eruption, described particularly over face, neck. This is a facial gland hyperplasia, which is on cheek, face, and nose. Most probably they're on nose. This is a malaria and it's 3 week old. And upper chest and back, and caused by equine sweat retention is most common in warmer climates. Management directed towards avoidance of excessive heat and humidity with lightweight loose clothing. These are given morphological description of skin lesions. Macule, flat lesion, localized color change such as freckle, papule, solid raised lesion less than 0.5, nodule solid raised more than 0.5 centimeter. Plaque is disc-shaped patch larger than 1 centimeter in diameter, psoriasis, an area of dermal edema, urticaria, and vesicle, a raised fluid containing lesion less than 0.5 centimeter in diameter, varicella, bulla, a raised fluid containing skin lesion more than 0.5, and the pustule is a raised pustular lesions, acne, respiratory atrophy, depression on the surface due to thinning of epidermis or dermis, burrow, linear papule 3 to 5 mm long, seen in scabies, comedone, blackhead, plug-in, sebaceous follicle containing altered sebum and cellular material. Crust consists of dry serum and other exudates. Cystic cavity lined with epithelium and containing fluid pus or keratin. Eczema, dermatitis, a pruritic inflammatory condition, papules and vesicles or erythematous base. Exfoliation, secondary infections, impetiganizations are common. Erosion and break in the skin with partial loss of epidermis, erythema, redness, excoriation, scratch which removes epidermis and may bleed. Cogner phenomena, the induction of the site of trauma skin traces present elsewhere. Psoriasis, lichenification, accentuation of the normal skin markings due to rubbing and atopic eczema. Nevus is localized malformation, tissue fracture, pruritus, itching, purpura bleeding into the skin or mucosa, small areas are petechiae, and large areas are ecchymosis. Purpura does not blanch at pressure, are formed by accumulation of excess of normal or abnormal keratin, full thickness, scales. A form of commission excess of normal and abnormal keratin, ulcers, full thickness loss of dermis in some dermis, bilication, surface depressed in the center, molluscum contagiosum, And bullous impetigo, this is an uncommon but potentially distinct form of impetigo. The most superficial form of bacterial infection seen particularly in newborn is most often caused by Staph aureus. Treatments such as systemic antibiotics, cloxacillin, melanocytic nevus moles, congenital moles occur in up to 3% units any that are present are usually small congenital pigmented nevi involving extensive area of skin. Nevi more than 9 centimeter in diameter are rare but disfiguring and carry a 4 to 6 month lifespan with no subsequent malignant melanoma. They require prompt referral to pediatric or dermatologist and plastic surgeon to assess necessity for the investigation or feasibility of removal. This will sympathetic and 12-day infect. Showing blisters. Melanocyte nevi becomes increasingly common as children get older in the presence of large numbers in adult may be indicative of childhood sun exposure. Large giant congenital pigmented hairy nevus, other smaller nevus are always visible. Prolonged sunlight should be avoided and sunscreen preparations with a sun production factor of 30 or higher should be applied liberally to expose skin in bright weather replied every few hours. Malignant melanoma is rare before puberty, except in dry acne. However, in adults, the incidence of malignant melanoma has been increasing for many years. Risk factors for melanoma include a positive family history, having large melanocytic nevi, fair skin, repeated episodes of sunburn, and living in a hot climate with chronic skin exposure to the sun. Parents should prevent their children becoming sunburned. Albinism is a genetic defect in biosynthesis and distribution of melanin. The albinism may be oculocutaneous, ocular, or partial, depending on the distribution of depigmentation in the skin and eye. The lack of pigment in the iris, retina, eyelids, and eyebrows result in failure to develop fixation. Reflex, this is pendular nystagmus and photophobia, which causes constant frowning. Correction of reflected errors in tinted lenses may be helpful in a few children. The fitting of tinted contact lenses from early infancy allows development of normal fixation. The disorder is an important cause of severe visual impairment. Pale skin is prone to sunburn and skin cancer in sunlight. A hat should be worn and high effective barrier cream applied to the skin. Epidermolysis bullosa, this is a rare group of genetic condition. Many types characterized by twisting of the skin and mucous membranes. Autosomal dominant variants tend to be milder. Autosomal recessive variants may be square and even fatal. Blisters occur spontaneously or follow minor trauma management directed at avoiding injury from even minor skin trauma and treating secondary infections. This rare forms of fungus and toes may be confused. And contractions will develop from repeated blistering and healing. Mucous membrane involvement may result in over-ulceration and cyanosis from esophageal erosions. Management, including maintenance of adequate nutrition and analgesia when dressings are changed, should be by a multidisciplinary team, including a pediatric dermatologist, pediatrician, plastic surgeon, and dietitian. Child oculocutaneous albinism with appearance the hair is silvery white. And these are severe autosomal recessive form of epidermolysis. This dermolysis is scarring following recurrent blistering. Milder form of epidermolysis in 3-year-old. There are blisters over the fingers which heal within a few weeks. So, neonate and collodion baby. This is a rare manifestation in inherited ichthyosis. A group of conditions where the skin is dry and scaly. Infants are born with the dots, shiny, parchment-like, or collodion-like membrane. This is a risk of dehydration. Emollients apply to moisture and soften the skin. The membrane becomes fissured and separated within a few weeks, usually leaving either thyrotic or far less commonly normal skin rashes of infancy. Nappy rashes are common. Some causes are listed. Irritant dermatitis, the most common nappy rash, is seen less frequently nowadays with the use of modern disposable nappies, but still occurs if nappies are not changed frequently enough or the infant has diarrhea. However, irritant dermatitis can occur even when the nappy's area is cleaned regularly. The rash is due to irritant effect of urine on the skin of susceptible infants. Urea spitting or calcium feces increase alkalinity and likelihood of a rash. The irritant eruption affects the convex surfaces of the vertex, perineal region, and lower abdomen and top of the thighs. Texturally, the flexure is paired, which differentiates it from other causes of nappy rash, rash erythematous, and may have a scalded appearance. Most severe forms are associated with erosions and ulcer formation. Mild cases respond to the use of protective emollients, whereas most severe cases may require mild topical corticosteroids while leaving the child without a napkin will accelerate. It is really practical at home. Canada infection may cause and often complicate nappy rashes. Rashes metis includes the skin flexures, and there may be satellite lesions, treatments with topical antifungal agents. Infantile seborrheic dermatitis. This eruption of unknown cause presents in the first 3 months of life, starts on the scalp as an erythematous scaly eruption scales. Form a thick yellow adherent layer commonly called cradle cap. Scaly rash will spread to the face behind the ears and then extend to flexures and apnea. Infant eczema, it is not itchy and the child is undeterred by it. However, it is associated with increased risk of subsequently developing infantile seborrheic dermatitis in a frontal cap, involvement of face eczema and napkin in seborrheic dermatitis. Napkin rash due to cancer infections, skin structures are involved when there is satellite pustules. Mild cases involve the emollients scales on the scalp then cleared with an ointment. Contain low concentrations of salicylic acid applied to the scalp daily for a few hours and then washed off. Widespread body eruption will clear the mild topical corticosteroid either alone or mixed with antifungal agent. This is itching, topical dermatitis, and change can worsen by rubbing, scratching. Itch is a key clinical feature in eczema at all ages, leading to an itch scratch, itch cycle, no itch, then it is not eczema. Some itchy rashes, atopic eczema, chickenpox, ethically allergic reaction, chronic dermatitis, insecticide, scabies, fungal infection, and traces, rosea. Atopic eczema, atopic dermatitis, prevalence of atopic eczema in children in the UK is about 20%. Genetic deficiency of skin barrier function is important. Pathogenesis of atopic eczema. Onset of atopic eczema is usually in the first year of life. It is, however, uncommon in the first 2 months, unlike infantile seborrheic dermatitis, which is relatively common at this age. There is often a family history of atopic disorders, eczema, asthma, allergic rhinitis, hay fever. Around one-third of children with atopic eczema will develop asthma. Exclusive breastfeeding may delay the onset of eczema in fetus-producing children, but does not appear to have a significant effect on the prevalence of eczema during later childhood. Atopic eczema is mainly a disease of childhood, being most severe and troublesome in the first year of life, resolving 50% by 20 years of age and 75% by age 16. Diagnosis may clinically the disease are usually severe, atypical, or associated with unusual infection of altering growth and immune deficiency disorder should be excluded. Immunological changes in atopic disease are probably secondary to enhance antigen penetration through a deficient epidermal barrier. Clinical features rashes may itch in many conditions, but in atopic eczema, itching pruritus is the main symptom at All lesions this results in stretching and exacerbation of the rash. The exfoliated areas become erythematous, weeping, and crusting. And distribution of the eruption tends to change with ages, and the decay of the skin is usually dry, and prolonged scratching and rubbing of the skin may lead to lichenification, in which there is accentuation of the normal skin markers. Complication causes exacerbation of eczema listed. However, flare-ups are common, often for no obvious reason. The eczematic skin can readily become infected, usually with staph or strep. Inflammation increases the avidity of skin from staph aureus and reduces the expression of antimicrobial peptides, which are needed to control microbial infections. Staph aureus thrives on ectopic skin and releases superandrogens, which seem to maintain and worsen eczema. Herpes simplifies infection, although less frequent, is potentially very serious that can spread rapidly on atopic skin, causing extensive vesicular reaction. Eczema herpeticum. Regional lymphadenopathy is common and often marked in active eczema, which usually resolves when the skin improves. Management number of treatment modalities are available, avoiding irritants if precipitants it is advisable. Avoid soap and biological detergents. Clothing next to the skin should be of pure cotton. Where possible, avoiding nylon and pure woolen garments. Nails can need to be cut short to reduce damage from scratching, and mittens at night may be helpful in the very young. When allergens such as the cow milk has been proven to be precipitant, should be avoided. Eczema infant more than 2 months of grumpy face also trunk, and older child with on reflection, infection, distribution rate of eczema. Distribution eczema tends to change with age. Infant's face and scalp prominently affected, although the trunk may be involved in older children's skin fractures, people in popliteal fossa infection areas such as the neck, wrist, and ankles are characteristically involved. Like implication and causes of exacerbation of eczema, bacterial infections, suffer and strep. By infection, herpes, ingestion of allergen, egg, contact with the empty allergen, environment, heat, humidity, change or reduction, medication, psychological stress, unexplained. Molars, these are means to management moisturizing, softening the skin. They should be applied regularly 2 or more times a day, and after a bath, they include ointments such as one containing equal parts of white soft paraffin and liquid paraffin. Ointments are preferable to creams when the skin is very dry. A daily or alternate day bath using emollient oil as a soap substitute is also beneficial. Topical corticosteroid, these are effective treatment for eczema but must be used with care. And mildly potent corticosteroids such as 1% hydrocortisone ointment can be applied to the eczema Sebaceous areas once or twice daily. Moderate potent topical steroids play a pivotal role in the management of acute exacerbation, but their use must be kept to a minimum. They should be applied thinly, and their use on the face should be generally avoided. Excessive use of topical steroids may cause thinning of the skin as well as systemic side effects. However, fear of these side effects should be better they use in controlling exacerbation. Immunomodulators in children over 2 years of age, short-term topical use of tacrolimus or ointment or microlimus cream must be indicated for eczema not controlled by topical corticosteroids. And where there is a risk of important adverse effects from further topical steroid use. Occlusive bandages, these are helpful over limbs when scratching and like identification are a problem. They may be impregnated zinc paste or zinc and tar. Paste bandages are worn overnight or for 2 to 3 days at a time until the skin has improved. Voice for itching in young children. Short-term use of red stockinette wraps may be helpful. Diluted topical steroids mixed with emollients are applied. The skin and damp wraps fashioned for trunk and limbs are then applied with overlying dry wraps or clothes. Antibiotic, antiviral agents, antihistamine, antibiotic hydrocortisone can be applied topically for mildly infected eczema. Systemic antibiotics indicated for more widespread or severe bacterial infections. Eczema herpeticum is acute and often widespread is treated with systemic acyclovir. Its suppression in eczema is with an oral antihistamine. The second generation antihistamines are not sedative. Antihistamines can be useful in raising the itching threshold so that scratching is reduced. Dietary elimination, food allergy may be suspected the child reacts consistently to a food or infants and young children with moderate or severe atopic eczema, particularly associated with gut Dismotility, colic, vomiting, altered bowel habit of altering growth. The most common food allergens resulting in eczema are eggs and cow milk. Allergen-specific IgE antibodies in blood and skin prick testing may be helpful but must be interpreted with caution. Dietary elimination for 4 to 6 weeks may be required to detect a response. A trial of an extensively hydrolyzed protein formula, amino acid formula in place of carbs milk formula may be undertaken in formula-fed infants under 6 months of age with severe atopic eczema that cannot be controlled by optimal treatment with emollients and moderately potent topical corticosteroids. Dietary elimination should be carried out with the advice of a dietitian to ensure complete avoidance of specific food constituents and that the diet is remain nutritionally adequate. The food challenge is required to be fully objective. Psychosocial support eczema can be sufficiently swayed to be disrupting both to the child and to the whole family. The parents and the child need considerable advice, help, and support. Health professions, other affected families, or fellow sufferers in the UK. National Eczema Society provides support and education about the disorder infections and gestation person fatigue has been considered earlier in the chapter and acute bacterial viral infections are considered in chapter 15. These are the assessment of child eczema. Condition of child distribution of eczema is often osculated, deep encrusted, like edified. How troublesome is itching, worse or better than usual? What causes exacerbation? Food, other legend, irritant, medication, stress. Does it disturb sleep? Does it interfere with life? Family knowledgeable about condition its management? Check. Any evidence of infestation, bacterial herpes simplex, problems from other allergic disorders, is growth normal? Management avoiding so frequently use emollients, avoiding iron and immune foods. Is there a need to give or change your medications, topical corticosteroids, immunomodulators, closer bandages, antibiotic agents, antihistamines, allergy test to egg, plus minus other foods? Is it indicated to identify coexistent IgE mediated food allergy on dietary elimination, or it is indicated? Is it indicated? So dietitian supervision need for psychosocial support. These are infectious correlated atopic eczema. Viral. These are viral infections and fungal infections. So viral infections are viral warts. They are caused by the human papillomavirus, of which there are well over 150 types. Warts are common in children, usually on fingers and soles, very cute, very care. Most disappear spontaneously over a few months or years, and treatment is indicated only if the lesions are painful and are a cosmetic problem. They can be difficult to treat, but daily application of a proprietary salicylic acid and lactic acid paint or a glutaraldehyde 10% solution can be used. Biotherapy liquid nitrogen effective treatment but can be painful and often needs repeated application as its use should be reserved for older children. Resting contagiosum. This is caused by pox virus, lesion or small skin colored early papule with central umbilication. Resting conditions, some of the pearly lesions show characteristic umbilication and this is ring of the scalp showing hair loss and carry on. They may be single but are usually multiple lesions are often visceral but tend to disappear spontaneously within a year if necessary. A topical antibacterial can be applied to prevent or treat secondary bacterial infection. Cryotherapy for a few seconds only can be used in oral and away from the face to hasten the disappearance of more chronic lesions. Fungal infection has a ringworm. Dermatophyte fungi invade dead keratinous structures such as a horny layer of skin, nails, and hair. Term ringworm is used because of the ringed annular appearance of skin lesions. A severe inflammatory pustular ringworm patch is called a carrion. Tinea capitis scalp ringworm sometimes scalp ringworm Sometimes required from dogs and cats causes scaling and patchy alopecia with broken hairs. Examination under filtered UV Woods light may show bright greenish yellow fluorescence of the infected hairs with some fungal species. Rapid diagnosis can be made by microscopic examination of skin scrapings for fungal hyphae. Definitive identification of fungus is by culture. Treatment of mild infections is with topical antifungal treatment. Topical antifungal preparations, but most infections require systemic antifungal treatment for several weeks. Any animal source of infection also needed to be treated. Tinea capitis, scalp, ringworm, annular scaling, scalp lesion, patchy alopecia, and with broken hair. Fungal hyphae on skin scrapings treated with topical or systemic antifungal treated dog or cat if infected by such infections. Cleavage is caused by infestation with the eight-legged mite Sarcoptes kb, which burrows down the epidermis along the stratum corneum. Severe etching occurs 2 to 6 weeks after infestation, bursts in warm conditions and at night. In older children, burrows, papules, and mosaics involve the skin between the fingers and toes, axilla and flexor aspects of the wrist, belt line, and around the nipples, penis, and buttocks. In infants and young children, the distribution often includes the palm soles and trunk. The presence of lesions on the soles can be helpful in making diagnosis. The head, neck, and face can be involved in baby, but is uncommon. Diagnosis made on clinical grounds, the history of itching and characteristic lesions, although burrows are considered pathognomonic, they may be hard to identify because of secondary infection due to scratching. Itching in other family members is a helpful clinical indicator. Information can be made by microscopic examination of skin scrapings on lesions to identify mite eggs and mite feces. Comprehensive skin becomes coriated due to scratching, and there may be secondary eczematous urticaria reaction masking the true diagnosis. Secondary bacterial infections common, giving crusted pustular lesions, sometimes slowly resolving. Nodular lesions, treatment as it is spread by close bodily contact with the child, and whole family should be treated whether or not they have evidence of infestation. Permethrin 5% should be applied below the neck to all areas and washed off after 8 to 12 hours. In babies, the face and cap should be included, avoiding the eyes. Benzyl benzoate emulsion 25% applied below the neck only in diluted form. According to the age and left for 12 hours is also affected by smells and has an irritant action. Malathion lotion 0.5% was another effective preparation applied below the neck left foot. The child and other member of the family itching suspect scabies. Head lice, profuse nits, egg capsules on visible scalps hair, live lice were visible on the scalp. Very itching burrows, papules, and mosaicals, distribution varies with age, scratching leads to scoriation, secondary eczematous or urticarial reaction, often with secondary bacterial infection. Not only the child but also whole family need treatment. Pediculosis, capitis, head lice infestation, is a common form of lice infestation. Children widespread and troublesome among primary school children. Presentation with bleaching of the scalp and nape or from identifying live lice on the scalp or nets, empty egg cases on hair. Louse eggs are cemented to hair, close to scalp and nets. Small whitish old capsules remain attached to the hair shaft as the hair grows. There may be secondary bacterial infection, often over the nape or the neck, leading to the misdiagnosis in pedicle. Suboccipital lymphadenopathy is common. Once manifestations confirmed by finding live lice and Dermaticon 4% lotion on aqueous solution of malathion 0.5% is dropped into the hair and scalp and left on overnight in the hair shampoo. The following morning treatment should be repeated a week later. Flammability of an alcohol-based lotion should be noted. Wet combing with a fine tooth comb brush to remove fat lice bug busting every 3 to 4 days for at least 2 weeks is a useful and safe physical treatment, particularly in parents treat with enthusiasm. Other childhood skin disorders, this is where disorder rarely presents before the age of the catate type is common in children and often follows a streptococcal virus sold through the ear infection. Lesions are small raindrop-like, round and oval erythematous scaly patches on the trunk and upper limb. An attack usually resolves over 3 months to 4 months. However, most get a recurrence of psoriasis within the next 5 years. Chronic psoriasis with plaques or annular lesions are less common. Fine wetting of the nails and seen in chronic diseases. One is unusual treatment from cotate. Psoriasis is with bland ointments. Coal tar preparations are useful for plaque psoriasis and scalp involvement. Calcipotriol, vitamin D analog, which does not stain the skin, is useful for plaque psoriasis in those over 60 of age. Bactrinol preparations are very effective in resistant plaque psoriasis. Occasionally, children with chronic psoriasis develop psoriatic arthritis. Chronic psoriasis may have a considerable effect on quality of life. Psoriasis association can be helpful in offering support and advice. With traces rosea, this acute benign self-limiting condition is thought to be of viral origin. It is usually begins with a single round or over scaly macule. The herald patch 2 to 5 centimeter in diameter on the trunk, upper arm, neck, or thigh. After a few days, numerous smaller, dull, pink macules develop on the trunk, upper arms, and thigh. The rash tends to follow the line of thread posteriorly, described at the fir tree pattern. Sometimes lesions are itchy, no treatment is required, and the rash resolves within 4 to 6 weeks. Alopecia areata is a common form of hair loss in children and understandably a cause of much family distress. Hairless, single, or multiple non-inflamed smooth areas of skin. Areas of the scalp, remnants of the broken off hairs visible, and sectionation mark hairs may be seen at the edge of the active patches of hair. The more extensive the hair loss, the poorer the prognosis. Regrowth often occurs within 6 months in localized hair loss. Prognosis should be more guarded in children with atopic disorders. This is the date solution of back and 5 years old headlights and alopecia areata, smooth radical patch of non-inflamed fall, hair fall, granuloma, and lily ringed. Okay, lesions are typically ringed annular with a raised touch, while a non-scaling edge, unlike ringworm, they may occur anywhere but usually over bony prominences, especially over hands and feet. Lesions may be single or multiple, usually 1 to 3 centimeter in diameter, tend to disappear spontaneously, but may take years to do so. There's also subcutaneous form. And